Welcome you back to our TAPISAR Journal Club, which regularly happens on every fourth Wednesday. So today we have some esteemed faculty with us, but before we begin, we request our lovable chairperson of TAPISAR, Dr. Sharath sir, to give the welcome address.
Thank you, Dr. Sindhuja. Good evening, everyone. Welcome you all for today's Journal Club meeting of TAPISAR. I'm grateful to our TAPISAR organizing committee, Dr. Kundavi, Dr. Vasundhara, and Dr. Sindhuja for their tireless efforts to keep the Journal Club meeting happening. Warm welcome to all the chairpersons, Dr. Indumati, Dr. Salguna Devi, experts and the presenting doctors. I'm happy for today's topic for discussion, obesity and infertility. Obesity is, we all know that obesity is increasing in epidemic proportions and becoming an important cause for infertility. And I'm confident that we'll all will be immensely benefited by today's meeting and to give precise and personalized care to the patients. With this brief introduction, I request Dr. Sindhuja to continue the proceedings. Thank you, Dr. Sindhuja. Thank you.
Thank you, sir. Vasundhara ma'am, I kindly request you to introduce the expert and speaker for the first session.
Yeah. It gives me great pleasure. Again, good evening to yet another journal club. Proud privilege to introduce a good friend, Dr. Indumati Joy. She is well known in the circle of reproductive medicine, a postdoctoral fellow in reproductive medicine, senior consultant at Nova IVF, over 15 years of experience. She's an invited faculty, also a fellowship examiner, and has authored many chapters in journals, peer-reviewed journals, and her areas of interest are minimal stimulation protocols in IVF and gynae endoscopy. And she's going to be the expert for the clinical topic. And can I have the next slide? The topic for today is medical therapy to treat obesity and optimize fertility outcomes in women of reproductive age, a narrative review. May I now request Dr. Indumati Joy to please take over the session.
Thank you very much, Dr. Vasundhara, Sindhuja, and Sharath sir for the opportunity. So, shall I introduce the speaker? Yeah. So, Dr. Indumati Krishnan, she shares half my name. So, she's a consultant in Dr. Aravind's IVF. She has 14 years of experience in obstetric practice and 5 years focus on infertility. And she finished her MBBS in 2003 and MD in 2010. And she also has special training in ultrasound, finished her fellowship and diploma in 2014 in World Laparoscopy Hospital in Gurgaon, and clinical embryology and reproductive endocrinology. And she's finished that in Delhi. Her special interests are high risk obstetrics, recurrent implantation failure, and male infertility. So over to you, Dr. Indu. We are looking forward for the topic which is very useful for us, obesity and the medical management of obesity in fertility seeking patients.
Thank you for the kind introduction, ma'am.
Ma'am, kindly note that there will be 2-second delay in changing the slide, ma'am. So please note that, ma'am.
Yeah. So thank you for the kind introduction, ma'am. I thank TAPISAR for giving me this opportunity, and my special thanks to Sarguna Devi, ma'am, for this opportunity. Ma'am, am I audible, ma'am?
Yes, doctor, you are audible.
It's clear, ma'am.
So the topic for discussion today is medical therapy to treat obesity and optimize fertility in women of reproductive age, a critical analysis done by Janelle Duma and David Silver, and which was published in Reproductive Biology and Endocrinology Journal 2025. A small introduction about obesity. Obesity is seen as a systemic disease, as a chronic, relapsing, multifactorial neurobehavioral disease, which results in adipose tissue dysfunction and abnormal fat loss, leading to adverse metabolic, biochemical, and psychosocial health consequences. So all of us know obesity, like the impact of obesity on infertility. So even a modest weight loss of approximately 7% can significantly improve the endocrine parameters, ovulation frequency, and menstrual cycle regularity, which enhances the rate of spontaneous conception and response to ovulation induction. Both ACOG and BFS recommends a BMI of less than 25 before initiating fertility treatment or deferring treatment until BMI is less than 35. So the aim of this review is to compare the relationship among obesity, infertility, and interventions, and to compare the safety, effectiveness, side effects, and suitability for different patient profiles. And it also identifies the impact of emotional factors because of obesity on success rate, on infertility success rates. And in this study, they have also identified the knowledge gaps and future proposal research avenues. CDC and WHO has classified obesity based on the BMI as overweight, obese, and severely obese. So this is the US data. So in US, among 27% of women over 20 years of age are overweight, and 41.9% are obese, and 11.9% are severely obese. So the adverse effect of the impact of obesity on infertility doesn't get over once the patient is conceived. Like it also continues in the pregnancy period and in the postpartum. So during the preconception period, why is obesity important? Because obesity, patients with obesity takes time to, take longer time to conceive than the normal women. And there is during the stimulation, there is increased need of gonadotropins. And they have poor oocyte quality and abnormal endometrium leading to implantation failure. So as all of us know, during pregnancy, there is increased incidence of gestational diabetes, hypertension, and fetal growth abnormalities, and there is higher rate of miscarriage and congenital birth defects. During the postpartum period, they are there is higher incidence of lifetime insulin resistance and cardiovascular diseases in women with obesity. So the obesity, fertility, infertility is all a vicious cycle. So the obese women are stressful about their body image, which is disrupting the HPA axis, which in turn affects the reproductive hormones and ovulatory function, which increases the obesity and infertility, which causes depression and anxiety in patients, leading to unhealthy eating habits, and there is obesity again. So this is a vicious cycle. So when patient comes to us for fertility treatment, so at that time when we advise for weight reduction, they are less receptive, and they don't accept the delay in fertility for just because of weight loss. So the most important period is during the preconceptional counseling period. This is the most receptive period to counsel the patient about weight reduction. So regarding this, there is a study done by Sacha et al. He evaluated 148 women over 45 years with infertility and recurrent pregnancy loss, and evaluated their prior weight loss experiences, attitude towards future intervention, and willingness to delay fertility treatment. Out of which 92% of overweight and 84% of obese women were not just willing to delay fertility treatment for more than 3 months. They wanted faster options of weight loss, start the process of conception, especially in older women. So this tells us the importance of preconceptional during the preconceptional counseling. So all of us are talking about weight loss is improving fertility outcome. So let's see, does it really help in improving fertility outcome? So these are all the older studies which was done. So the data shows there is no improvement in, improvement in live birth rate is controversial and it is incomplete. And a larger RCT studying effect of live birth rate have generally included interventions based on diet, exercise, and orlistat. So orlistat, which we don't use it at present because of the side effects, and smaller RCTs have conflicting results on this. The highest amount of weight loss achieved was 22 pounds in the smaller RCTs which was conducted. So the weight loss intervention in fertility treatment trials have not shown significant improvement in live birth rate, but there is definitely reduction in pregnancy associated complication and increase in spontaneous conception. So all these are the older studies where the newer group of drugs were not included in the studies. So now we are coming to the pharmacotherapy treatment, which is the main topic of today. Currently, there is 6 FDA approved medications available for weight loss. This thing, and among the 6, 3 are injectable, and 3 are last 3 are oral medications. So in injectables, we have GLP-1 receptor agonist. GLP-1 is glucagon-like peptide receptor agonist, and another one is GIP. GIP is gastric inhibitory peptide. So in GLP-1 receptor agonist, we have 2 drugs currently, which is in the market, which is liraglutide and semaglutide. And GLP-1 plus GIP with dual component. Tirzepatide is the one with the dual component. The last 3 combination of naltrexone and bupropion, and next is phentermine plus topiramate and orlistat. So naltrexone, the first 2, Contrave and Quismia, is not available in India, and orlistat we are not using at present because of the less efficacy and more side effects. So we will see in detail about the GLP-1 receptor agonist today. So first is about the GLP-1 receptor agonist. GLP-1, the native hormone GLP-1 is a naturally occurring hormone which is secreted majority from the L cells of small intestine. It is also secreted in pancreas and brain in small quantity. So what is the stimulation for secretion of this hormone is your carbohydrates and fat ingestion. So the mechanism of action is when food enters inside the stomach, the GLP-1 receptor is secreted from the small intestine, and it causes delay in gastric emptying, and in the pancreas it causes increased insulin secretion and reduced glucagon, which increases the insulin sensitivity. Thereby, it is very useful in patients with diabetes mellitus. And in CNS, it causes increased satiety and reduced food intake. So the native hormone GLP-1 has a very short half-time, very short half-life, whereas the GLP-1 receptor agonists have a longer half-time and hence potentiating the effects. So now we have seen the mechanism of action, how it acts. This is the comparison of the 3 drugs. The first one is the liraglutide, which is liraglutide and semaglutide or GLP-1 receptor agonist, whereas the third one, tirzepatide, is the GLP-1 receptor agonist plus GIP, gastric inhibitory peptide. So it has got tirzepatide is a combination of both. So let's see the dose, efficacy, and administration. Liraglutide and semaglutide. Liraglutide is given as a daily injection, daily subcutaneous injection, whereas semaglutide and tirzepatide is given as a weekly subcutaneous injection. So the dose is liraglutide is 0.6. I mean, starting dose is 0.6, and maximum is 3 milligram. And semaglutide, the starting dose is 0.25 milligram to 2.4 milligram. And tirzepatide, the dose is 2.5 starting dose, and maximum dose is 15 milligram. When you see the efficacy of weight loss among the three, tirzepatide has got the maximum efficacy because it's a combination of both. The next is the semaglutide, around 14 to 17%, and liraglutide has the least efficacy of 6%. So we have seen the dose, efficacy, and administration. So based on their half-life, liraglutide is advised, is stopped 2 weeks before planning the pregnancy, and semaglutide and tirzepatide are advised, it is stopped 2 months before planning the pregnancy.
Your voice is a little breaking,
advantages
actually.
agonist. Ma'am,
Yeah.
now, ma'am.
Yeah, good.
Okay, ma'am. Ma'am, shall I continue, ma'am?
Yes, ma'am. Please, ma'am.
Okay, fine. So the advantage of GLP-1 receptor agonist are it causes significant amount of weight loss, like around 6 to 30% or greater in 3 to 6 months. This can be considered as an option for women who wants faster weight reduction, who are not willing to delay fertility treatment for longer periods. So other than weight loss, GLP-1 receptors are also located in the reproductive tract of most mammals. So it has got the anti-inflammatory effect and anti-fibrotic effect on the gonads and the endometrium. So this can be used even for PCOS and endometriosis patient who has the inflammatory component in addition. Next slide, please. So as we said, there are studies which shows there is reversal of PCO morphology and decrease in androgen levels in women with PCOS who have used GLP-1 receptor agonist. There is one pilot study which has shown combination of liraglutide plus metformin for this is for a period of 12 weeks. It is written as 2 weeks. So for a period of 2 weeks in obese PCOS women has a better pregnancy rate when compared to using metformin alone. So the GLP-1 receptors are not without any side effects or contraindication. It should be it is definitely contraindicated in patients with personal or family history of medullary carcinoma, thyroid, or Mentu syndrome. Generally, we ask patients for the patient's history, but before starting the GLP-1 receptors, we should also ask for the family history of any thyroid cancer, and it is contraindicated in patients with pancreatitis or any biliary disease. The side effects are the most common side effects. Side effects were confined to GI in nature, and most of it occur during the dose escalation. So initially we start with the lower dose, and based on the weight reduction, we escalate the dose. So all these side effects were seen, the GI side effects were seen during the dose escalation period, and it got decreased over a period of time. Other less common side effects are insomnia, hypoglycemia, headache, and fatigue. So next is regarding the teratogenicity effect. Novo Nordisk Safety Database in 2016, they studied around 271 cases of liraglutide exposure during pregnancy, out of which like 49.9% live birth rate was there without congenital anomalies, and around 1.8% had congenital anomalies, and 34 patients had fetal loss, and 18% of the patient got to terminate the pregnancy. So this data is in par with the women who did not receive the medication. So there is no much of difference in the teratogenicity. And data currently is this is for the liraglutide, and data is currently insufficient for semaglutide and tirzepatide. So, what the manufacturers recommend to avoid teratogenicity is we have to stop the drugs 2 weeks before planning pregnancy in case of liraglutide, and 2 months before conception. 2 months before for semaglutide and tirzepatide. So next is about the safety concerns. Teratogenicity, we have already spoken. Like we have to stop 2 months prior. Next is about the first trimester exposure to semaglutide. Like in animal studies, it has, does not seem to have increased major birth defect. And next is about the cost. So for 1 month, approximately weekly injection for 4 weeks. For 1 month, the cost is around 20 to 25,000. And next problem is the weight regain. So people regain regain about 2/3 of their weight loss within a year after stopping the GLP-1 receptor agonist. So we have to highlight the need for strict lifestyle adherence post cessation. Which is very important before, which is very important in counseling before starting the therapy. So we have seen the injectable ones currently, which is available in the market and which we are using. Next is about the oral medication. There are 3 oral medications. First one, the brand name is Contrade, and it contains naltrexone and bupropion. So that it targets the appetite regulation and metabolic pathway. Basically, naltrexone is an opioid antagonist, which is commonly used for alcohol and opioid use disorder. So it blocks the mu opioid receptors in the brain. It modulates the physiological drive to consume. It controls the hunger signals in the hypothalamus, causing reduced intake of food, thereby reducing the cravings and compulsive eating behavior. So bupropion is an aminoketone antidepressant commonly used in tobacco disorder and in patients with depression. It inhibits the reuptake of neurotransmitter, dopamine and norepinephrine, which are integral to mood regulation and mesolimbic reward system. So the combination of these both drugs results in amplifying overall appetite suppression and craving reduction, thereby reducing, increasing the weight loss. So it is beneficial for patients with emotional and reward-driven eating, like binge eating, lazy eating, and other things. So there is a limited data on the use of low-dose naltrexone in PCOS patients and in endometriosis. Next slide. So this is regarding the contraindication. Should not be used in hypertension, seizure disorder, bulimia, and anorexia nervosa, and patients with abrupt discontinuation of alcohol, benzodiazepine, or antiepileptics. Next slide. So the dosage is, during the first week, we start with the lower dose, like 1 tab, 1 OD, and slowly we escalate the dose up to 2 BD. Next slide. The common side effects are related to GI, and severe side effects like elevated BP, heart rate changes, and it is hepatotoxic, and there is risk of seizures. Next slide, please. So the weight loss with this medication is around 5.4% versus 1.3% in placebo in 56, which was achieved in 56 weeks, as documented in COR trials. So it doesn't other than weight loss, it also improves the metabolic disorders. However, the effect of this drug on female fertility is not accepted. Next slide, please. So this is regarding the safety concerns. There is increased risk of fetal loss and congenital anomalies, which was reported, and the drug has to be stopped 2 weeks before conception based on its half-life, and it is to be avoided in lactating women. There is no research on regain of weight after stopping the medication. Next slide, please. So this is regarding the next oral agent, Prisminia, which contains phentermine and topiramate. Phentermine suppresses the appetite by affecting multiple neurotransmitter pathway, and topiramate modulates the GABA receptors, mitigating cravings and
Doctor, we are unable to hear you actually. The voice got cut off actually.
And this was a study with now, ma'am. Am I audible, ma'am?
Yeah, now
yeah,
it's okay.
yes.
Yeah.
Now we are okay. Ma'am, okay. So this is regarding the second oral agent, phentermine and topiramate. So phentermine suppresses the appetite basically by affecting multiple neurotransmitter pathways, and topiramate modulates the GABA receptors, mitigating cravings and increasing fullness. So the weight loss is approximately 10.9% as per the Concord trial, which was done in around 2,400 patients. So this, based on this evidence, they say like for long-term management, we can use this agent. And next slide, please. So the contraindication is hyperthyroidism and glaucoma. The side effects are paresthesia, dizziness, dysgeusia, insomnia, constipation, and dry mouth. And there can be severe cognitive impairment, and if there is mood disorders, metabolic acidosis, tachycardia, and most importantly, teratogenicity with topiramate. So, as I said, topiramate is a known teratogen, so it should not be used. Whereas we can use only this component, phentermine alone, for short-term modest weight loss. Next slide, please. So next is about the orlistat. Orlistat is a lipase inhibitor. It prevents absorption of approximately 30% of ingested fat, and it is very rarely used now because of the lowest efficacy and significant GI side effects. We don't use orlistat now. Next slide, please. So we have seen the injectable ones and we have seen the oral medications, and next is about the surgical management. So bariatric surgery is effective long-term solution for sustained weight loss. Individuals with higher BMIs unlikely to achieve weight loss bariatric surgery is indicated for patients with higher BMIs who are not able to who are not responding for medical management. So with bariatric surgery, the weight loss is around 60 to 70%, which is on par with semaglutide and tirzepatide. Previously, bariatric surgery was considered the most durable method before the arrival of GLP-1 receptor agonist. So the indication for bariatric surgery is if the BMI is more than 35 without any comorbid illness, it is an indication for bariatric surgery. For patients with BMI more than 30 with comorbidities, they are also a candidate for bariatric surgery. So the disadvantages is like post-bariatric surgery, they recommend a waiting period of 1 to 2 years to attempt conception. And so because of this waiting period of 1 to 2 years, it is not an option for patients who wants to conceive quickly. And the most important disadvantage is it causes vitamin and mineral deficiencies, which can impact the maternal health and fetal health. So other than this, there is inherent surgical risk, like there is increased risk for post-operative complication and intestinal hernias in subsequent pregnancies. So this is a study done by Hasib et al. Who compared the semaglutide with the ESG is endoscopic sleeve gastroplasty. So he compared the effectiveness and efficacy and the cost effectiveness in comparing the both. So in that endoscopic sleeve gastroplasty is cost saving compared with semaglutide, but there is no data available about other bariatric surgeries or another population outside class 2 obesity. So this study compares only semaglutide and the endoscopic sleeve gastroplasty. Next slide, please. So coming to the conclusion, clinically significant and meaningful weight loss is definitely achievable with pharmacotherapy to enhance fertility in women of reproductive age. Current research supports use of weight loss medication for enhancing spontaneous conception and response to ovulation induction. Further research on the effects upon live birth rates are warranted. So for meaningful weight loss, right now, GLP-1 receptor agonist can be considered for use in the peri-conception period as long as they are stopped at least 2 months before conception. And the oral medication can be considered as well, though result in less weight loss. Phentermine and topiramate are teratogenic, but can be used with contraception for weight loss before trying to get pregnant. Next slide, please. Next slide. So these are the key gaps identified by the review. Like we need large RCTs regarding the live birth rate using the GLP-1 receptor agonist, and regarding the safety of GLP-1 receptor during the pregnancy, and the mechanism of oral medications is on long-term effects on female fertility is still lacking. Next slide. and only one study like which compared the effectiveness of steel gastroplasty and semaglutide was there, and but data is missing for the other traditional bariatric surgeries and for the tirzepatide, and there is no conclusive data whether this can be used in the data for it. Next slide, please. Next slide. And these are the drugs which are about to come in future. This is regarding the injectable ones which are available. They are trying to make it oral. So oral, we have GLP-1 receptor agonist. Right now we have semaglutide in tablet form, and so others are all yet to come. Thank you, ma'am.
Dr. Indumati?
Ma'am, can you hear me, ma'am?
Yeah, thanks. Dr. Indumati Joy, are you there?
Yeah. Hello,
Yeah,
can you hear me? Yeah.
Yes.
Dr. Indumati, it was a good presentation. It was a good overview about the whole article. I had read through the article this morning, the one which you are presenting now. So it's a narrative view. Basically, it means that we don't have good published data. That's what it means. It's like a hearsay. Like they collect the data and they go in for a discussion, and then it's a narrative review. So which means basically that you need to have more subjects and more studies to substantiate the thing. So long back when obesity was a major issue, the metformin used to be used, and I remember the days when metformin was contraindicated in early pregnancy, and we used to stop once the patient conceived. But now it is not like that. We have so many studies regarding metformin and its use in obesity and in pregnancy that we can blindly use that medication now. But as of now, the statistics say that in India, this is the second leading drug. The GLP-1 RA is the second leading drug in sales. The first one is Augmentin, and the second one is this. That's what the statistics say in the paper. So, which means that every diabetologist and endocrinologist have started using this. So, they are using it right, left, and center on diabetic patients and patients who want to reduce weight. This is very easy because it works on the brain level and the hypothalamus, and it acts on the satiety center. So, they have an aversion to food. So it works very well for the first 1 year. But the minute they stop using those medications, then again, the mind is very powerful. It cannot be stopped by just a tablet. So my point is always this weight reduction is an ongoing process with continuous counseling and change of lifestyle. Your food habits, the way you eat, the way you feel about it, and the psychosocial factors have to be addressed. And along with all this only, we can give any medication for that matter. So, but all these, whatever you have mentioned, the 6 varieties, they are trying, but GLP-1 has passed the test of the time. I think the last 1 year, it has been number one drug in India. So thank you so much for the presentation, and I was also benefited from this. Thank you so much.
Vasundhara,
Yes, sir.
I can make a small
sir.
comment. Yeah.
Yes, sir.
So, Dr. Indumati, it was
Yes, sir.
extensive and beautiful talk, no?
Yes.
Congratulations. Okay. We're all benefited by your talk, no?
Thank you,
Okay.
sir.
So just I did attend the advisory committee meeting of Nova Nordics, no, regarding that
Yes, sir.
semaglutide, no?
Okay.
So actually, I wanted to inform you, know, as we gynecologists are not allowed to prescribe the semaglutide, no. If you wanted to prescribe that medicine, you have to refer the patient to the
Refer to
endocrinologist.
endocrinologist.
Yeah. So that point I wanted you to know, make a note of it. And the second thing, coming to the bariatric surgery, I had a patient with polycystic ovarian syndrome with obesity, and this lady first, no, beautifully she responded to the recombinant FSH, and many follicles developed, and I was so happy to take her for oocyte retrieval. To my surprise, no, I couldn't get any eggs actually, to be honest to you. There maybe one or two GVs I might have got it, but what she did go for bariatric surgery. She lost weight and she has come back again. We have subjected her for oocyte retrieval. This time, no, she developed beautiful oocytes, and formed the beautiful embryos, and she did conceive and had a baby. So definitely bariatric surgery. And there's another lady who had bariatric surgery. She conceived on her own, and she has come for antenatal checkups. So bariatric surgery has an important role in the management of obesity and infertility. Thank you. Thank you so much.
Thanks, Dr. Indumati. Thanks, sir, for those very practical points. As you say, we should not jump into a newer drug which is going to be producing wonder where there's an indication for bariatric surgery. Even, we have had a couple of patients who had bariatric surgery. Before that, they have had IVF cycles which never resulted in embryos. And then post-bariatric surgery, it's to the surprise that, they were already counseled for donor eggs. And then now they're able to go for their self gametes. So wherever there is a morbid obesity where, medical management or your lifestyle changes is not going to, give any improvement. And it has also caused some metabolic syndrome and uncontrolled, diabetes or all other comorbidities associated with obesity. Definitely bariatric surgery, we need to counsel because still patients' acceptance is not very much towards the bariatric surgery. That needs to be there. And as Dr. Indumati Joy was telling, that psychosocial aspect is an ongoing process because they're always depressed about their body image. And, that itself is causing binge eating. She put a very nice slide of that vicious cycle in her presentation. So I think it is a multidisciplinary thing. And as Sir said, if you're going to use Ozempic or anything like that, we are not medico-legally, safe to use those drugs. And what to watch for, how much to monitor them for pancreatitis and other things. I think we should be, safer and wiser in jumping to newer drugs before we have how metformin safety is proven beyond doubt. Until that time, we cannot give unrealistic pictures to the couple. And also 2 weeks washout period is enough, sir. They have mentioned somewhere the data is 2 months stoppage of the drug before we start on infertility.
I think 2 months will be a good idea. Yes. Yeah. You should not jump in fast.
Thank you, Dr. Indumati. That was really nice and the need of the hour topic for all of us to listen. Can we move on to the next topic, sir? So if there are no questions, is there anything on the chat box? Somebody has asked, why no Orlistat, ma'am? Why shouldn't we not use Orlistat? Dr. Indumati, you were mentioning something about
Actually,
Orlistat is
yeah.
not indicated. Actually, it's not indicated. It's not safe to use in pregnancy. For a patient who is going to have a fertility treatment, it is only a drug that is used for absorption of fat by 30%, and it also has extensive side effects when compared to the other GLP. So that is why it is not indicated. And many studies, they started with Orlistat, but now they have stopped. They are not using it now.
Yeah. Dr.
Because other
Vasundhara?
methods have come.
Yeah. Dr. Vasundhara?
Yes, sir.
Are you there? Yeah. Regarding this Orlistat, so they did a study in Australian study where they studied about 700 gynecologists, so about that Orlistat, whether they are using that Orlistat in their practice or not. 70% of the gynecologists are hesitant to start Orlistat on their own. So most of the times, we do refer them to the endocrinologist to start the medication. And according to Dr. Indumati, it was not that effective. She was telling, Orlistat, and these days.
So actually, the methodology of taking the medicine also, they are supposed to take it 1 or 2 hours prior to food because it just causes fat absorption and produces steatorrhea. So it doesn't actually produce so much of a weight loss. So
that's true.
That's one thing. Sir, any personal experience on Monjaro for anyone in your patients?
Not yet started.
Till that no notice person comes and says, then we say that you please go through some national body, involve all of us in a multicentric trial so that we have some data.
Yeah.
Sir, with your permission, can we go ahead with the next one,
Yeah,
sir?
next, sure. Please, Amma, please, Vasundhara.
Sindhu?
Yes, ma'am. Sariti. It is my honor to invite our expert for the next session, Dr. Sarguna Devi ma'am, who needs no introduction. She's a senior clinical embryologist And she's the director of embryology at Dr. Arvind's IVF chain of fertility clinics with over 20 years of clinical experience with regulatory awareness, establishment and maintenance of IVF labs, quality management and clinical audits, training and development of embryologists. Ma'am has also had experience of working in the UK for quite a long time. So she has a very multidisciplinary approach to embryology. Ma'am, I welcome you and I kindly request you to introduce the speaker for today and take over the session, ma'am. Ma'am, you're on mute, ma'am.
Ma'am, are you able to unmute, ma'am?
Ma'am, you unmuted, ma'am.
Oh,
No?
I'm unmuted.
They
Yes,
can
yeah.
hear you, ma'am.
Yeah. The host is not allowing participants to unmute themselves initially. Thank you so much for that kind introduction. And do you have the slide for Kode? Yes, yeah. I'd be happy to welcome Dr. Kode Nachiyar Anbaragan, who I know for a while, and she has been working with me and I know about her. She's an MBBS graduate and she was a state rank holder during her period at +2. And she has done her master's in clinical embryology and andrology from USA. And her current position is senior embryologist for Salem branch of Dr. Arvind's IVF. And she has previously was trained in working as an embryologist and an academic coordinator at ERC Fertility and Research Center with me. And I would welcome Kode now to deliver the presentation on impact of obesity on in vitro fertilization outcomes, a systematic review article.
Good evening, everyone. Can you able to hear me, ma'am?
Yes.
Yeah, thank you. Thank you, Dr. Sarguna Devi, ma'am, for your kind introduction. And also, I would like to thank TAPISAR for giving me this opportunity. Today, I will be presenting the systematic review, impact of obesity on in vitro fertilization outcomes by Bodati, Noor, and Ansar et al. This article was published in Curious in 2025. So what is the context to have this discussion today? As we all know, obesity is a major public health concern. The obese adult population stands at 650 million and women is a significant part of it. And we know it directly impacts fertility by causing issues like anovulation, menstrual irregularities, and infertility. Consequently, a growing number of women with elevated body mass index are turning to IVF. While the general link between obesity and infertility is clear, the exact degree and mechanism by which a high BMI compromises the highly controlled process of IVF has been a subject of ongoing debate. This systematic review aims to synthesize the evidence and provide a definitive answer. So what is the objective of this particular paper? The study aimed to comprehensively synthesize literature to establish a definitive quantitative link between female obesity and IVF, key IVF endpoints like a live birth rate, clinical pregnancy rate, implantation rate, and miscarriage rate. The study also tried to elucidate the underlying biological mechanism. Secondly, it's trying to find the influence of obesity on different stages of IVF, like ovarian stimulation, follicle maturity, and embryo development. Finally, the study also tries to provide evidence-based clinical guidelines on preconception weight management for patients undergoing IVF and formulate recommendations. Next slide. So coming to methodology, the study employed a systematic review methodology adhering strictly to PRESMA guidelines to ensure methodological rigor and transparent reporting. And the search strategy included employed by the authors were extensive, and it was conducted across multiple major databases, including PubMed, Medline Central, Cochrane Library, Science Direct, and MDPI Search Scope. The study timeline included articles from January 2023 to May 2024. The study included randomized control trials and observational studies that compared IVF outcomes in obese women to normal weight controls. Study quality was assessed using standard tools, the Cochrane Risk of Bias 2 scale for RCTs and Newcastle Ottawa scale for observational studies. Included in this study are peer-reviewed journals, study reporting IVF outcomes, while gray literature that is unpublished data, conference abstract, and those articles not published in peer-reviewed were excluded from the study. From a total of 533 articles, a final cohort of 13 studies was primarily analyzed via a narrative review necessary due to the significant heterogeneity across the included studies. These 13 articles included in this particular study are 6 retrospective cohort studies, 1 RCT, 2 systematic reviews, 3 narrative reviews, and 1 case report study. The results from the study can be subdivided into 2 categories, the quantitative impact and the metabolic disturbances. Coming to the quantitative impact, the study findings are decisive. Obesity is consistently correlated with lower success rate across all major IVF outcomes. There is a 10 to 15% decrease in clinical pregnancy rate in obese women. Crucially, a dose-response relationship was confirmed. The greater the BMI, the worse the prognosis. For every 5-unit increase in BMI, there was a significant 5 to 7% reduction in live birth rate. The miscarriage rate was also increased. According to the study, it was increased by about 20 to 30%, underscoring a risk beyond just implantation failure. We can also see from the study there is a decreased implantation rate, fertilization rate, and increased chromosomal abnormalities. And it's interesting to observe that when in the couples when both are obese, the study points that there may be a decrease in the number of available embryos and their quality. Coming to the next slide, please. Coming to the metabolic disturbances, the study says the reduced success is explained by 2 distinct biological pathways, one that affect the egg quality and second the uterine environment. So increased metabolic disturbances such as those related to insulin resistance, elevated estrogen directly harm the quality and the development of the eggs and ultimately the embryo quality. The uterine endometrium is also affected by these hormonal disturbances. Obesity also leads to a chronic low-grade inflammation and oxidative stress, creating an unreceptive or hostile environment in the endometrium. This further leads to impaired endometrial receptivity, and there is also reduced embryo quality. The study also points that elevated inflammatory markers like tumor necrosis factor alpha and interleukin 6 may lead to reduced implantation and clinical pregnancy rate. This is a graphical representation of the findings so far we have seen from the study. The bar chart highlights that the clinical pregnancy rate, live birth rate, fertilization rate, and endometrial receptivity were all reduced, while the miscarriage rate and chromosomal abnormalities are increased in obese individuals. Next slide, please. Coming to the discussion part, the study review is in agreement with what is already known, that it's a confirmation of the negative impact of obesity on IVF outcomes. The study reiterates that there is a dose-response effect that increased BMI worsens IVF prognosis. Specifically, a 5-unit increase in BMI will have a 5 to 7% reduction in live birth rate and clinical pregnancy rate, and a 9% increase in miscarriage rate. Sorry, previous slide itself. The study also points that there is a need for higher dose of gonadotropin and longer stimulation days in obese women, but does not exactly dwell deeper into this subject. Another point is, though the study speaks about how obesity affects both oocyte and embryo quality, the magnitude of the impact is not well established in the study. Coming to the clinical implications and recommendations from the study, this systematic review provides strong evidence to support the recommendation that preconception weight management is a clinical necessity. Interventions like diet, lifestyle changes, and exercise and bariatric surgery are shown to have a positive impact on improving IVF prognosis. Even a 5 to 10% weight loss is highly beneficial, as it restores hormonal imbalance, boost oocyte quality, and decrease miscarriage. The study recommends to have a tailored ovarian stimulation protocol and drugs to each patient, but again, no specifics are provided in the study. The study points it is essential to address comorbid conditions like PCOS, insulin resistance, and type 2 diabetes while treating obese women. The review also recommends psychological counseling to alleviate the stress and anxiety that the patient may undergo because of societal stigma, body image issues, in addition to having the infertility problems. The biggest limitations of the study was the heterogeneity of the included articles, which resulted in varying in protocols, different BMI cutoffs, and difference in patient population. Also, a very low number of randomized control trials is included in the study. All this made it a narrative style review rather than a full meta-analysis. Future directions. What we need right now is systematic studies on weight management interventions with emphasis on when and how much weight loss would be beneficial to IVF. For example, this particular study points that the weight loss should happen when it happens 6 to 12 months prior to the start of IVF treatment. The benefits are more pronounced. More research to describe the exact molecular mechanism behind all this is needed, as it will enable to provide targeted treatment to improve reproductive outcomes. We also need longitudinal studies in the future to see the long-term health outcomes of children born to obese mother through IVF. Last but not the least, we need studies that analyze the effectiveness of mental health interventions in improving the IVF outcome in obese women. The key takeaway from my journal article is, first, there is a consistent and strong correlation between obesity and lower IVF success rate, which we all know. Obesity affects every stage of IVF, from egg quality, egg number of oocytes retrieved, to sustaining pregnancy. A clear dose-response effect of BMI and IVF outcome is established from this study. The study also points that there is a dual mechanism of failure. One is the impaired oocyte quality, and second one is the reduced endometrial receptivity we can see in obese women. It is a must that there should be a preconception weight control counseling and treatment prior to the start of IVF treatment, and it should be a multidisciplinary approach involving endocrinologists, dietitian, reproductive specialists, and psychological counselors. Thank you.
Thank you so much, Kodai, and that was a very good presentation indeed on the systematic review on the effect of obesity onto IVF outcomes. So we need to discuss about the oocyte quality, embryo quality, and the clinical outcomes. This is what is just been there, because clinically it has been discussed very widely in the previous presentation. So it's a good job done, Kodai. Good. And talking about the review articles, as we all know, there are numerous studies available. Some support obesity has an adverse effect onto IVF outcomes, some does not. They do not see any significant difference between the healthy controls as well as the IVF obese women with IVF treatment. So what they have done an extensive search in the systematic review, because we are on to this that in the laboratory we always have surprises. Sometimes you get good embryos out of the woman who you expect not a good result. So what do we do? But this is giving an answer that they have selected only 13 studies at the end, but they have just given viable information, which is high BMI adversely affects the oocyte quality, embryo formation, clinical pregnancy, and live birth rate. They also say there is a high incidence of miscarriage rates observed in the studies. So this is the information what we have got from the review. So, and I wanted to really just quote some important article that was published in 2015 from Hull University, UK, but it is quoted in many of the references. You can see many of the articles for obesity versus IVF outcomes, where they have done little extra. They were not just comparing these ones from a normal culture. They have done a time-lapse culture using Primovision time-lapse system. as well as they have done a spent culture media analysis from both the groups, so that they've just done they measured the consumption and released amount of glucose, pyruvate, amino acid, lactate, as well as they have measured the triglyceride levels within individual embryos. So it was quite interesting. So what was the finding they had? They found these obese women, the embryos derived from obese women, they have grown faster up to day 4, probably up to a morula stage, very quick. But then later they have had lesser cells present in the blastocysts, whatever blastocysts they have formed, less trophectoderm cells present, and they had reduced glucose consumption, modified amino acid metabolism, and increased levels of endogenous triglycerides. This is a very, very new information for us, right? So some way they are trying to say, like the embryos during their development from the obese woman, they are showing a difference. So this could be causing the negative impact onto the clinical outcome. That is one study. So obviously, like how you explained, that metabolic dysfunctions, especially which are related to the lipid metabolism, what we are talking about it, because it's obesity, they could be contributing to the lower quality oocytes and the malformed embryos. These metabolic errors can also cause higher incidence of chromosomal aneuploidy, which could be contributing to the higher rate of miscarriage. This is one hypothesis. Is it true or not? We don't know. So now we have to really see what our advanced technology like time-lapse, later you have like nicely developed morphokinetic time-lapse systems available. So what are these studies, as well as the PGT, the ploidy status study using PGT technology? Are they saying something to us, like looking into the studies? There are quite a lot of studies available again. And these time-lapse studies, some of them have shown slower early cleavage kinetics from the embryos from the obese women comparing the healthy weight controls. But there was no difference observed after that. So in terms of blastocyst formation, say it's the number of blastocysts, or the quality of blastocysts, or the clinical outcomes associated. This is from the largest scale TL studies, I would say. This is from that. So there is no difference. And secondarily, the PGT studies. So regarding chromosomal normalcy, these PGT studies are saying like obesity does not appear to have any impact onto the ploidy status. So the euploid numbers were very similar between both the groups, and the aneuploid rates were not increased because they were obese. So this information is available with the latest technology and the latest reports. So in spite of all these things, why do we still have worse IVF outcomes from the women? Means it is something else. Means they are just concentrating now onto the endometrial receptivity, maternal metabolic epigenetic environment, or uterine implantation use. So these are the reasons which could be contributing to the poorer outcomes from the obese women when they are undergoing IVF. We know there are limitations between these time-lapse and PGT studies, different setup, different platforms, a different patient pool, whatever, but this is the information what we have got from them. To support that, there are some other studies where these obese women have had embryos from donor oocytes from the and with the husband's sperm. They're again, like this is just as little support for the previous studies, whatever they are saying, that the oocyte quality does not matter here, but the endometrial receptivity, because they are still having worse IVF outcomes from the donor oocyte cycles, which means we may have to really think about the endometrial receptivity on the other side in a better manner when we are treating the patients. Again, male obesity, there have been reports, and male obesity combined, and when they are coming down for treatment to us, is there any effect? Yes. Again, this is having a negative impact onto the embryo quality, implantation, as well as clinical pregnancy, etc. So that is very true. When it comes to male obesity, so what could be causing the male obesity? The mechanisms may be high estrogen, the decreased testosterone, whatever. So the ROS levels are high, there are epigenetic changes. The scrotal temperature may be slightly increased, so it could be causing lower sperm quality, their functionality, the high DNA fragmentation, there could be high ROS production, as well as lower mitochondrial activity. So is there any correction method available? That is to the clinical part we are just giving. So you're correcting and you're just, or if you just lose the weight and coming into the healthy weight, is it corrected? That is another area of discussion. So I wanted to just conclude with just one study, which is reported very recently, it's in July 2025 from Spain, that collectively analyzes the data from 15 different institutes and a huge number of embryos, like 30,000 embryos being analyzed. So they have just given one line conclusion that is very interesting. The higher the female body mass index, the higher the number of oocytes, embryos, and embryo transfers needed to achieve a live birth. So obviously, weight management as well as lifestyle modification are ultimately recommended before the IVF cycle is being commenced. So as we all say, we need more prospective studies, specifically examining obese versus normal patients using time-lapse monitoring or PGT or non-invasive methods where the spent media is just giving us more information. It's all required. And investigation on the uterine endometrial receptivity is also important to study the impact on the woman. So in practice, in the laboratory, we do nothing. So it is like any other patient who is coming in. If the sperm is needing some other advanced selection method or something, we are just doing it. And eggs, we don't do anything because we can't change anything inside. So it's like a normal treatment within the laboratory. But I would like to hear from the experts what they would just comment on this, and then the inputs will be very useful to all of us. Thank you so much.
You literally covered like every single point, I think. Like any question that arises in the mind, you've already answered so clearly.
I had all these
In
questions.
such a organized manner. Thank you so much, ma'am, for absolutely summarizing and giving us so many points.
Thank you.
Thank you. Actually, you brought into the aspect of male infertility also the how it has hormone dysregulation and how it can affect the sperm quality, the scrotal temperature, ROS, everything. And just like how you were mentioning that, it could increase the ROS in the male, I think even a female who is obese is going to have, oocytes with more ROS. It's like quite natural, and the competency is going to come down, whatever it is. So you had brought in all those insights, and in the lab, if you are, having the luxury of an embryoscope, you can probably, differentiate, because oocytes, you're going to, culture it any which ways in a similar manner, whether it's an obese patient or a normal BMI patient. Having said this, I had a nice paper which I read. This obesity, has got different reproductive outcomes in different ethnicity groups. For example, if the obesity level is more in the American, African, or Hispanic groups, and they are, PCOS, they had a more higher miscarriage rates. Indians, they have a truncal obesity. They're more prone for, gestational diabetes and pregnancy complications. So I think this obesity, again, has got a lot of ethnicity component to it, and that can translate into different reproductive outcomes as well. So we need to look at what kind of population we are dealing with. And also in India, there can be a lot of difference in the diet and obesity across north and south itself. We might be having differences in the way obesity is, and based on their eating habits and everything. It's quite interesting to actually read all these papers. So thank you so much, Dr. Sarguna Devi, for summarizing the whole thing. And if anybody else, Radha ma'am, Sarath sir, anybody else wants to say something, please.
I just wanted to add one point. We are talking only about the overall as an obesity. There is a concept about the visceral obesity. So when we are planning for the weight reduction program, it is not only the weight reduction as such. It is the visceral the thing which contributes for a successful outcome. So there are some studies where they have measured that visceral obesity also. So that has to be given little importance. That's what I felt. And one query was then if we are not supposed to prescribe those drugs, then why the pharma companies are coming and meeting us? Because
so that you will refer them to endocrinologist, ma'am. Endocrinologist or a diabetologist.
And
because
also
they are the regular users.
They have their own monetary, this thing, ma'am, endocrinologist, and then they can deliver the drug directly to the patient at a different cost. So
that you will refer.
No.
That's why they are asking us to.
No, because I have a couple of people who are on these medications, and even the nephrologists are also prescribing that. Okay. So what they are saying is that initially there is a reduction in the weight, and later it becomes static.
Yeah.
So that is one thing which they have seen. That is what I thought I should share with them. Of course, the cost is very significant,
Right.
and that
First
needs a lot of
10 months, it is showing good result, ma'am. After that, it is becoming static. And also, Dr. Sarguna was asking something. If they reduce the weight, remarkably weight reduction is there in a few months, will the quality of the oocyte or the sperm is going to change? Actually, it is not. It's a no, actually, because they are the environment, the micro environment in the body is adapted, and the epigenetic changes have already occurred depending
Yeah.
upon when the obesity starts. So if you're going to be a childhood obesity, and then I think the damage is already done. Even if you're going to take this injection and GLP for 1 year, you won't get the same environment. Maybe temporarily they will have that, but that adverse effect on the oocytes, which had already started, is actually not reversible. And also, if the obesity is a short-lived one, like for example, post after the menarche, they are fat for as a teenager for a few years, and then they realize and they come back to the normal weight before wedding. These are the women who will have a better outcome when compared to the childhood PCO with more androgenic PCO also. So PCO also plays a role. So it's the micro environment and the prolonged duration which is more important than these injections, which can reduce the weight temporarily.
Yeah.
Okay, madam.
And one more thing is they are suggesting is a washout period of 2 months. So that 2 months is known to, they can put on the weight again.
Again, yes.
So we
yes.
really don't know, because
Yeah.
that person had come to me from Bangalore with the study details. I had asked him for all the literature. So he was saying that there is not much of studies, and he wants to get some of the things which are available. But the washout period is one thing which is something we should give importance, because when they are reducing the weight, there are chances that they can conceive spontaneously also. So whether we should advise them contraception during this period, I really don't know, when they are on medication. Because he said there are no known teratogenic effects, but still he says long-term the studies are
The
not there.
studies are
So,
not enough.
yeah, so we know that when they reduce even 5% of the weight, they have a improvement and they can conceive spontaneously. So how do we treat this is another thing which we have to give importance.
We are just looking at it for obesity management, ma'am. Diabetologists are using it even in
Yeah.
female patients for this thing, and they're in the reproductive age group. So we never know what is going to be.
Yeah.
Ma'am's videos.
Thank you, Dr. Kodai, ma'am, and thank you, Sarguna Devi, ma'am. Ma'am, I request Radha ma'am to kindly give the vote of thanks and close the session, please.
Yeah. It was really a very good topic which was selected, and something which is upcoming and needs to be given importance. I thank Dr. Indumati for their active participation, and also Dr. Kode and Dr. Sarguna Devi for their very good presentation. And I also thank the Shield for the wonderful for this platform where they are sharing it with us every month. Thank you one and all the delegates who have joined. Hope they are all benefited by this the Journal Club. Thank you, and I thank
you,
once again the team of TAPISAR who is behind this Journal Club, Dr. Kundavi, Dr. Vasundhara, and Sindhuja. Thank you one and all.
Thank you, ma'am.
Thank you.
Thank you,
Thank
Dr.
you.
Sarguna
Thank
Devi.
you.
Thank you, Indumati Joy. Thank
Thank
you.
you.
Thank you all the.
Thank you,
Thank
ma'am.
you. Thank you.